Modern life. Between careers, kids, and health, it can be mayhem. That's why we're here. I'm Dr. Lisa Varghese-Kroll.
And I'm Dr. Lonray Falusi. We're physicians, moms, and longtime friends who break it all down for you. Wondering how to juggle all the balls and still stay sane? Looking for advice but don't want to be overwhelmed?
Curious about how to make the most out of life for your family but enjoy it at the same time? You're in the right place. Welcome to Health and Home with the Hippocratic hosts.
On this episode, we're talking about long COVID, or PASC, or PASC. How common is it? What are the symptoms? And how can we treat it? We're joined by an expert who tells us all of this and more to help you protect yourself and your loved ones. Hey, Lise.
Hey, Lon. Well, we've come a long way in our almost 3 years of producing this podcast, right? Mm-hmm. And COVID has been our companion the entire time.
Sadly, that is hard to believe, but true. We originally started this podcast in part to provide a reliable source of scientific information in response to this pandemic. And if we think back, our second episode ever was a primer on COVID-19 and everything we knew about it then, way back in April 2020.
Wow. Oh, we were so young and innocent back then.
Yes, little did we know.
And then our episode 6 was on the then novel COVID vaccine. Episode 11 was about the pros and cons of sending children back to in-person school during the pandemic. And episode 23 was about the COVID vaccine and health equity.
Yep. And episode 26 was about travel in the time of COVID and the new vaccine. Episode 36 was about mental health during COVID. Episode 38 was about the Omicron variant. And episode 48 was about the COVID vaccine for our little kids under 5.
So naturally, almost 3 years in, it's now time to talk about long COVID. So what do doctors and researchers know about the long-term health effects of this virus, and how can we best protect ourselves? Well, we're fortunate to have an expert joining us today to share with us everything we need to know. Dr. Alba Azola, MD, is a rehabilitation physician and the co-director of the Johns Hopkins Post-Acute COVID-19 team, PACT, in collaboration with the Division of Pulmonary and Critical Care Medicine at Johns Hopkins Hospital in Baltimore, Maryland. PACT is a multidisciplinary clinic that offers comprehensive outpatient care and rehabilitation services for patients with post-COVID conditions, and it was established in April of 2020. Dr. Azola's expertise includes neurorehabilitation, management of autonomic dysfunction, rehabilitation for swallowing disorders, and post-COVID rehabilitation, and she's one of a small group of physicians in the U.S. who are at the forefront of post-COVID research and treatment. So welcome, Dr. Azola.
Hi, thank you so much for having me and getting to chat a little bit about long COVID with you.
Oh, we're excited to have you.
Yeah, thanks so much for joining us.
Yeah.
So we wanted to jump in and have you maybe give us some background on long COVID or PASC, maybe starting first with just some numbers. What is the prevalence of long COVID among adults and among children?
So long COVID is a term that was patient-generated, patients that were getting infections and kind of weathering the acute illness at home started noticing this new onset of symptoms. And they started to find each other on the internet. And that's how the hashtag long COVID came along. Initially coined by Elisa Perego, who's an Italian PhD doctor who was suffering from the symptoms. The medical community and the scientific community had created different terms. There's the WHO post-COVID conditions, which is has a Delphi process definition for the term, with patients that have new onset of symptoms after acute COVID that lasts for 2 months and present within 3 months of the infection. So that is kind of the more accepted formal definition. But there's also the term post-acute sequela of SARS-CoV-2 or PASC, which is used mostly interchangeably with long COVID. And this kind of is a big umbrella term that covers sequela of the acute COVID infection, independent of severity, for both people that were severely ill initially and those that had milder cases with lingering symptoms. In terms of the prevalence, there's a lot of work being done in this area. I would say in general, we quote between 10 and 30%. It really depends on the cohort that they're looking at during the study. And I would say that, for example, in the CDC had set a number about 1 out of 5 people. However, during that questionnaire, they looked at lingering symptoms for 4 weeks after infection. So when looking at the number of people with symptoms for at least 3 months, that number changes to 1 out of every 17. So it's a little bit different. So it's hard to say, but I would say anywhere between 10 to 30% of patients that get infected will have some lingering symptoms, and some of them will have symptoms for 3 months or more.
I mean, that's a pretty significant number,
Right.
10 to 30%, and possibly even higher, depending on how you measure it. Yeah.
Right. And for example, if you think about the United States, right now we're above, I think, 10 million people that had the infection. I'm sorry, 100 million people. So if you say 10%, that's 10 million people in the US right now experiencing long COVID.
Wow.
It's a significant number. And I think that one of the main issues is that we don't have the medical community capacity to tend to the needs of this large population of patients.
Absolutely. And is there a difference in the prevalence between adults and children? Do we have enough data to speak on that?
Basically, there's certainly an effect in children. The clinical picture can be a little bit different, especially in the younger children, because they have MISC or multi-system inflammatory disease, and that's a little bit of a different clinical picture. And then there is some commonality between the younger adults that I see and then the teenagers, that they tend to have similar comorbidities or similar commonalities between those patients that get autonomic dysfunction, like POTS, and they're a little bit more of a similar group of patients, especially those that were not acutely ill.
So it's interesting. So, you've mentioned a couple of the symptoms that we tend to see that kind of got some of these patients communicating with each other on social media and other venues. What are some of the primary symptoms that you're seeing in your PASC patients? Kind of, if you had to pick the top 5, what are you seeing the most commonly?
Yeah, absolutely. The number one most common symptom is fatigue. It doesn't all present exactly the same, but fatigue is certainly the most prevalent. Secondary, I would say, difficulty tolerating upright position or orthostatic intolerance. Typically, symptoms such as palpitations, lightheadedness, nausea, flushing, sweating can be seen in this patient. So it's an intolerance to an upright position. Also, we see a lot of diffuse body pain, so more like a fibromyalgia patient population. And we also see a group of patients with small fiber neuropathy that have kind of the neuropathic polyneuropathy presentation, pain, sharp shooting, sometimes feeling of burning feet or things like that. And then I would say that there's another last one that would be the ones with cognitive impairment, which can combine with any of the other ones that I just said. But this, some of them are just purely cognitive impairment without the other symptoms that we see.
That's the scariest one, isn't it? Goodness.
Yeah.
Yeah, it's so sad to see people that were highly functional engineers do a MOCA test and get a 23, right?
Right. And for our listeners, can you clarify what a good score is on the MOCA?
Yeah, a perfect score would be 30. A passing score would be 27. But
that's a big drop.
That's a big drop.
Yeah.
Not on a healthy 48-year-old who's at the peak of his, working career. So.
That could be debilitating, right? I mean, any of those symptoms, but certainly, right, the cognitive issues, fatigue, that's really tough.
Yeah, it's interesting. It's a spectrum, right? And in our clinic, we started our clinic in April 2020 as a telemedicine clinic, and then we expanded to in-person services. And there's a large spectrum of the patients that we see. Even those with not severe acute illness, we see patients that are, debilitated to the point that they're almost bedbound or housebound after a mild COVID infection. And then we also see people, for example, that are runners that now have trouble hitting the same marks that they did before, and they have, decreased activity tolerance and shortness of breath and things like that. So it's there's a large spectrum of patients.
And for people who are listening now and either have COVID right now or recently have it and are wondering, am I at risk for developing long COVID? What would you say are some of the risk factors for developing long COVID?
Non-hospitalized adults, female gender, ethnic minority, socioeconomic deprivation, smoking, obesity, and decreased age. Risk factors for patients with severe acute infection involve other comorbidities like cardiovascular disease, diabetes, again, obesity, history of autoimmune disease, high viral load during acute illness.
Yeah, that's, I think not something that we generally tend to realize as a group, that younger age can actually predispose you to a more severe presentation of this. Now, you mentioned that, lower socioeconomic classes or certain ethnic minorities might be more prone. Which groups tend to be at risk due to health inequities?
Yeah, and I think this is, I'm going to get on my soapbox.
Please do.
Please do.
You can borrow ours.
Yeah, so definitely we know, right, that the people of color and lower socioeconomic status had higher risk of infection with COVID, given their work, given their roles in society. And we had clear numbers of those hospitalized patients, how Latino populations, Black populations were higher than white populations. When it comes to long COVID, the majority of the patients that come to our clinic are patients, Caucasians, with access to care. So when it comes to at least our clinic's view of long COVID, the population is very skewed. And we know we're not capturing because of the barriers to access to care. So part of what we do is educate the community. As a Latina, I try to educate through local radio and things like that, educating people about what is long COVID, what symptoms are not, are concerning, or you should go to your primary care about. So also educating the public about long COVID and that there's something that can be done. That's number one. And then number two is, the fact that there could be medical biases, right? In the referral, the way that a Latina expresses their symptoms with orthostatic intolerance can be different. And sometimes it can be interpreted as an exaggeration or, perhaps dismissed. And I mean, a lot of long COVID patients face gaslighting and dismissing from the medical community. But in particular, those populations that are already at higher risk, there's many reasons why they're not coming and getting treatment for long COVID.
You can get on that soapbox with us anytime. I think those are just such important points, right? Because just as you said, sometimes we see the list of risk factors, but we do have to delve in and ask, why. And you brought up so many good points as to why. Access to care and, the jobs that people have may put them at higher risk, and lack of sick days and that sort of thing, or paid sick days rather. So that's really helpful to hear, and time will only tell as to how we can. Time and lots of advocacy, I guess, can tell us to how we can improve the access to clinics like yours, or other places where people can get the help that they need once they've been diagnosed. So to that point, how is long COVID or PASC diagnosed? Is there certain protocol? It sounds pretty complex, right? So how do you go about diagnosing it?
Yeah. So The diagnosis of long COVID is a clinical diagnosis at this point. There is no particular blood test or exam result that can lead to the diagnosis. So it's based on the clinical evaluation. Of course, I don't like saying that long COVID is a diagnosis of exclusion. I think as physicians, we know and understand certain causes of fatigue, for example, or causes for cognitive dysfunction, for example. And as our due diligence, considering it a differential, we want to rule out other potential causes for those symptoms that they're experiencing, mostly because we actually can, target and understand the particular cause, right? So,
Right.
And I've had patients with elevated TSH or like low hypothyroid, that we caught when we were screening them at the clinic.
Interesting.
Just simple things like that, or vitamin D deficiency or vitamin B12 deficiency.
Right.
So it's important to kind of do the workup. But once we have addressed anything that can be attributed to a cause that we know and understand how to diagnose and treat, then we're left with the component of post-viral illness. And that's a little bit more complex, right?
Right. I mean, that's hard. That's hard for patients and for physicians, right? Neither of us like that situation. But this is also, I think, the result of being only not even 3 years into this pandemic, right? So, I mean, research takes time and we have to follow cohorts over a prolonged period of time. So what we know now may not be what we know in 5 years, but this is very valuable because we know so much more now than we knew 3 years ago.
Actually, very early on the pandemic, through the Academy of Physical Medicine and Rehabilitation, we formed a multidisciplinary PASC collaborative where we have about 41 post-COVID clinics throughout the nation where we have regular meetings, and we created writing subgroups for different topics. And in the interest of spreading the knowledge that we have gained over the past months,
right.
So we've been able to publish 6 guidance statements, particularly on breathlessness, on cognitive dysfunction, on dysautonomia, on cardiac complication or cardiovascular complications, cognitive dysfunction, fatigue. So we've been working on trying to spread what has worked for us, what type of how to streamline the workup that becomes more high yield for the physicians out there seeing this 10 million people.
Right. You and I are both members of AAPMNR, the American Academy of Physical Medicine and Rehabilitation. We're both physiatrists. And I think that is so key. That's how we're going to improve care nationally, is that all the physicians of any specialty that are caring for these patients, we've got to share our knowledge. And that's, I'm, proud and happy that has been a major initiative on the part of the Academy. And that being said, even though we are only 3 years into the pandemic, what treatments are currently available? What, do you tend to be offering these patients? And as a rehab physician or a physiatrist, how does rehab medicine play into how we'll think about and treat PASC in the coming years and coming months and years?
Yeah, I think physiatry is, as a specialty, is particularly well placed to tackle some of this long COVID issues, especially because these are chronic issues that affect function. And at this point, as the science is catching up in terms of pathophysiology and potential interventions that can target the specific causes of the symptoms, we're mainly right now on the stage where we can symptom manage. We can improve, make modifications so that the quality of life improves and the functionality and independence of those patients improve. So that's what PMNR brings to the table. And we also are used to working in big teams, right?
Right.
So we can sit at the table with neurology, with cardiology, with pulmonary. I think at this point, like I said, mainly targeting symptoms. When it comes to, for example, fatigue, like I said, the thorough workup initially. Once we have ruled out other causes of fatigue, we work a lot on energy conservation strategies, such as pacing, prioritizing, planning, and positioning. And we have, for example, occupational therapists and physical therapists that help also coach the patients through that. We give them some materials so that they can go through their day and see how they can make those changes, whether it's dividing tasks into smaller pieces instead of trying to push through a big task, taking breaks in between, sitting down when they're showering instead of standing up. So little things like that can be quite changing for this patient, and allow them to actually do more. The fatigue in long COVID is like being an iPhone 13 and now being an iPhone 3.
Oh, what an analogy. Yeah.
For the Gen Zers out there so they can understand.
I actually confirmed this with like a cell phone engineer person. So, you have to be very careful about where you invest your energy and how many apps you can run at one time before you crash, right? So that's a very important piece. And then particularly important is identifying those patients that have post-exertional malaise or post-exertional symptom exacerbation. This is a group of patients that respond differently to our typical rehabilitation strategies, right? These patients, for example, doing activities that would not cause exhaustion, like doing their laundry, going for errands, experience an exacerbation of symptoms of this sensation of body heaviness, almost like they want to test for COVID again because they feel like they're sick. Some of them experience neurologic symptoms like tinnitus or tremors. And this can come 12, 24, or 48 hours after the inciting activity, which is really interesting. So some of my patients call it the Thursday or the Friday flu.
Oh, wow.
Because, like I would say the more mildly fatigued patients, they're kind of pushed through the week, and it comes Friday and the whole weekend they're in bed. Their bodies are feeling ill. They can't get out. And then you have others in the spectrum that are way more limited, right? I have a patient that crashed because she walked her son to the stop bus, for school.
Oh, wow.
That made her crash for like 2 weeks. So it's a spectrum. But the point is that lifestyle modifications and learning how to implement energy conservation strategies in your day-to-day life is one of the key portions. We have been introducing things to our practice, such as low-dose naltrexone. Low-dose naltrexone is medication used for fibromyalgia with some supporting evidence. It's limited, but it helps with also chronic pain. So those patients that have chronic pain and fatigue, we see that low-dose naltrexone can also be helpful in their recovery and helping them regain some of that energy.
It's really amazing that in less than 3 years that we have, I say we, but really like the scientific community has come up with some treatments to at least alleviate some of the symptoms. So, and as you said,
that's heroic, really.
I think so too.
Yeah, well, I just want to say that this type of post-infection fatiguing illness and post-infectious dysautonomia, which we can talk a little bit more about later, are things that have been observed for decades, purely understood, purely researched. And for example, I'm in an institution where I have somebody who is the 25-year veteran of chronic fatigue syndrome management, and I have somebody who's a POTS specialist. And I was able to say, hey, like, what is working for this patient? Because I see some commonalities. And then we were able to start borrowing some of the tools from this people. For example, in the chronic fatigue patients that have fatigue and autonomic dysfunction, we've been implementing with very careful selection of patients using things like mestinon, which is repurposing a drug that is used for myasthenia gravis, that it's been used off-label by physicians that treat autonomic dysfunction. as well as chronic fatigue. And there's evidence emerging on the use of that for improving activity tolerance, as well as improving autonomic dysfunction symptoms and increasing overall parasympathetic tone, which is really helpful in some of these patients. So a lot of the treatments that we're implementing are kind of being passed on from this other specialists, there's not that many of them. Yes, I started by sending the patients to this specialist, and they quickly became overwhelmed. So they had like 2-year wait. And I was like, I can't have my patients wait 2 years. So let's see how it's done. And the same thing with immunology. There's a subgroup of patients with long COVID that present with mast cell activation syndrome, which is kind of a disorder of the mast cells. So it releases allergic kind of red flags, right? And it activates that response. So we've also been able to kind of talk to our immunologist and borrow from their knowledge what type of intervention. So for example, this patient population that presents with mast cell activation, they all present with itching, dry skin, eczema, exaggerated response to allergies, food allergies that they did not have before. They can have swelling of the lips, eyelids, throat, even anaphylaxis reaction in the most extreme cases. But in this patient population, we can do high doses of H1 and H2 blockers, so antihistamines and famotidine, for example, at kind of a double dose than the usual over-the-counter prescription, can actually help decrease that response and reduce some of the symptoms. So those are simple things that we've been able to kind of implement for our patients and improve their symptoms, improve their lifestyle.
I don't know if people realize the level of collaboration that goes on among medical specialties and physicians. And I just think that's so wonderful. It's one of the things that actually drew me personally to medicine. And I just being able to see the fruits of that in a global pandemic, really, I find very heartwarming. I'm so grateful.
And everybody was ready to help.
Right.
You know?
And I think that's so impressive, right? It's the thoughtfulness of the research that's come through really to try to attack this issue, I think has been really impressive. And you described some of the research that has helped us to get to the point now of some of these treatments and even figuring out how to diagnose it. Is there more research coming down the pike that you think will be helpful?
There's a lot of research that is happening. I think we are at a better place than we were 3 years ago, of course. We know a lot more, but we certainly don't have all the answers, and the patients are suffering. So there's a lot of work that needs to be done. So there's work to be done in the realm of identifying specific pathophysiology of the symptoms. It's still rather unclear. I personally think that by grouping all long COVID patients into one group and studying them, it's kind of muddying the waters. And you're not clearly seeing biologic markers and things like that because of the different endotypes within long COVID. So I think and it's starting to happen in the literature that's coming out, is starting to look at specific subgroups of long COVID and trying to understand what is specifically contributing to those. And, there are several different pathophysiologic mechanisms that are being studied, including autoimmunity, which certainly there's supporting evidence emerging that some of the symptoms in long COVID are caused by an autoimmune response. There's also changes in the endothelium, the inflammation of the lining of blood vessels. That is another area that's being studied. But which patients are truly having this particular pathophysiologic mechanisms happening to them? That's really where the answer is going to be able to understand how we can specifically help different patients with their different symptomatology. So it's not just one cure
monolith.
for COVID. It's going to be how we can get better at treating and targeting treatment specific to the pathophysiology. Yeah.
That makes sense.
Absolutely.
What we've seen about this virus is that it's different than most others. And each person seems to have a different set of symptoms. So it makes sense that long COVID presents differently from person to person. And there may be subgroups in there that we still have to sort of tease out.
Yeah, and there's another big theory is about the viral persistence, and there's certainly also growing evidence of virus reservoirs in different parts of the body, GI tract, in the brain, and the lungs. So that is another theory. And for example, now the RECOVER study, it's moving into the stage of starting clinical trials for interventions. One of the main starting trials is going to be Paxlovid, and the use of Paxlovid in patients with long COVID, given this theory of viral persistence in these patients.
Gosh, it's the variability of expression and the persistence of this virus that make it such an unholy terror, such a challenge. So, we've talked a lot about how patients with long COVID are suffering and, the research that is being done to try to alleviate some of that suffering. Are there any preventative measures that we can take that we know about at this juncture?
Yeah, absolutely. I think one of the best studies that came out of the VA in the past 2 months, I think, is the Paxlovid. They looked at patients that received Paxlovid during acute illness and those that did not. And they saw an improvement in long-term symptoms in those patients that did receive Paxlovid. And we can go back to the risk factors and how higher viral loads are considered one of the risk factors. So Paxlovid will decrease the viral load during that acute phase. So we certainly have growing evidence showing that using Paxlovid helps decrease the risk of long COVID. Also, obviously, vaccines. Vaccines are not bulletproof against long COVID, but they certainly have a protective property when it comes to long COVID. And it varies depending on strains, and the newer strains are more evasive of our immune system and are able to be passed on, but there's certainly a protective effect.
Component to vaccines, yeah. And then all the things we already know, right? Like we know how to do masking and isolation, these kinds of things, right?
Yes.
That maybe
Thank you for bringing
socially,
that up.
right? People are not so excited about, but it doesn't change how effective they are.
Yeah, it's really sad, especially like this past few months when we've had such a surge, not only of SARS-CoV-2, but of RSV
and flu,
influenza.
Right.
And, I think simple social measures like distancing, mask wearing, increased hand washing are simple things that we can do that we know are efficient in decreasing that
cost
transmission.
nothing. Yep.
And yeah, I mean, my kids still mask at school. I still mask at Target.
Right. Yeah.
Yeah. When right, it's hard to unknow it. Yeah.
Exactly. And as you said, these are measures that either are free or low cost, right? And, it's great to hear that there are treatments like Paxlovid and others down the line that may reduce the risk of long COVID, but we love thinking upstream and thinking even more about sort of that upstream prevention. So always wanting to highlight that. I think that's great that you brought that up.
I wanted to say, I'm sorry, the antibodies, so monoclonal antibodies are not effective on this newer strains of COVID. So some of those big tools and fancy tools that we were kind of trying to quickly send out to the clinical practice are now becoming less active against those viruses. So nothing replaces prevention, especially at the level of community.
Right, absolutely. And if someone out there thinks that they may have long COVID, what should they do? Who should they see? What would be your recommendation?
Yeah, this is always a tricky question. I absolutely believe that in order to meet the needs of the millions that are experiencing long COVID, primary care physicians should be the first person to go to be able to get an evaluation for the symptoms and start at least ruling out common things. And there's a lot of education that can go a long way when it comes to improving and lifestyle modifications and simple modifications that can be done, energy conservation strategies. So I have a very intense interest in educating primary care physicians so that they can start implementing these strategies that have been working for us for 2 years now, or almost 3. I think that that's going to be a key piece of providing care for long COVID patients. Long COVID clinics are very few of them, and they're difficult to sustain in the medical care system. They do not exist without support from the health system, for example. The level of overhead costs that it involves, being able to navigate patients through this complex medical care and close follow-up and things like that. It becomes difficult to sustain. And we unfortunately have seen some long COVID clinics closing, but I think the concept is going to be growing the education of what we have learned to the primary cares.
It's interesting because you've mentioned a couple of times, the question of not just sustainability of this relatively novel clinic, but also the question of access, and the fact that even if there were no inequities in the system whatsoever, just sheer numbers would swamp the available care. So what do you think, what's your opinion about what this will mean long term for the U.S., the healthcare system, and not just the U.S., but globally, knowing that this is, something that's going to be with us for a while?
I mean, long COVID is a mass disabling event. There are millions that are impaired to the point where they're not able to function on their normal day activities, including work. This is affecting the U.S., affecting the whole world. So I think that the vision long term needs to be ready to tackle this. Right now, I feel that as the medical community, we haven't turned on the red flags and alerts as we need to. This is impacting people, is impacting productivity, is impacting millions of lives, and it needs to be studied with more urgency and provided care with more urgency as well.
I'm curious as to what your thoughts on why we haven't. As you said, it's a mass disabling event, debilitating for millions of people. What do you think are the barriers for those red flags to go off, for funding to flood the space and all of that? What do you think is or the barriers?
There are several factors. I think one factor is that these post-infectious fatiguing illnesses have been neglected for so long. In terms of federal funding for research and support in the medical community at large. We're not even taught about, most people that go to med school are not taught about autonomic dysfunction or PASC.
Right.
They're not taught about chronic fatigue syndrome. And sometimes people say that it's not real, right? That this is just anxiety. Patients are dismissed because our routine tests don't capture the pathology. So I can say that there's certainly a component of the physician community accepting this and treating patients and acknowledging patient symptoms. So that's a big paradigm shift that needs to happen. So I think that it's one of the main barriers. I think that the needle is certainly moving on the right direction. But it's a big culture shift.
Yeah.
And it's hard as a provider because you signed up to make people better, right?
Yep.
And with these patients, you're trying, and sometimes they'll get better, sometimes they don't. But I think for this patient population, the value of having acknowledgement of their symptoms well, it goes a long way, as well as feeling that they're being supported through the process and not dismissed. It takes you a long way. and it helps them immensely. We also utilize, as part of our team, multidisciplinary team, neuropsychologists, rehab psychologists that help people, for example, with spinal cord injury, with brain injury, with strokes, to cope with impairments. This patient population are having impairments that are as impactful as some of those diagnoses.
Right.
So implementing rehab psychology can really help the patient navigate through this new personality of having a disability. And one point that I really wanted to make before we end is this is a vulnerable patient population. And in this age of rapid access to information and spread of information, there's so much misinformation out there.
Yes.
Absolutely.
There is many targeting this vulnerable population and profiting from this population. And it's important for them to, for physicians to advise adequately, right, about the evidence that supports certain use of different treatments that are being offered. I have patients, for example, doing like GoFundMe so that they can get this stem cell treatment in Mexico or something like that. And
right.
Oh my gosh.
Such a feature of the U.S. healthcare system. It's heartbreaking.
So true. Yeah, that's really sad that people, not surprising, but sad that people are profiting off of this. And I think to that point about misinformation, just want to put a quick plug in for our show notes at hippocratichost.com. We'll include some vetted, reliable scientific resources for people. So thank you for bringing that up, because you're right. There is a lot of misinformation for us to fight out there.
Well, thank you so much, Dr. Azola. You have just given us a massive treasure trove of your wisdom, your experience, and we appreciate that so much because, as we've said, this is really uncharted territory for all of us as a global community. And I think for our listeners, they will appreciate just as we appreciate you sharing your time with us, and hopefully, this kind of being the beginning of some of us having some of that education and being able to navigate these waters a little bit more mindfully for our patients, for those of us that are physicians, and for ourselves and our loved ones, for those of us that are not in the healthcare community, so that, we can really kind of alleviate some small piece of this suffering and these symptoms.
Thank you. We learned so much.
Anytime. It's my pleasure.
Thanks so much to Dr. Alba Azola for joining us today and for sharing so much useful information on long COVID and the tools we have to address it. For more info on her background and more resources on PASC, check out our show notes at www.hippocratichost.com. So that's our show for today. Thank you so much for joining us as always. Please follow us on Facebook, Instagram, and Twitter. And if you like what you're hearing, please subscribe and review us in Apple Podcasts. That means so much to us because reviewing the show helps other people like you find the podcast. And we might pick your review to share in a future episode. For example, VT10GDK said, really informative and a lot of fun to listen to. Thanks, VT10GDK.
Oh, thanks. We appreciate you.
Thanks, everyone, and talk to you soon.
Thanks for listening to Health at Home with the Hippocratic hosts. Remember that all views expressed here are our own, not our employers, and all content is for informational purposes only and should not be construed as medical advice, nor the establishment of a doctor-patient relationship. Always consult your own physician or healthcare team for any medical issues.
If you enjoyed this episode, please rate us, subscribe, and tell a friend. And check out our website at www.hippocratichosts.com for show notes on this and all our episodes. Can't wait to chat with you next time.